doctors and...
Hey, no, I just had behavior.
Oh, yeah. Oh, you did?
Yeah. For a little while. I can catch you up.
Okay. Promise.
Okay.
Okay.
Yes. Probably.
Ladies and gentlemen, Dr. Shead.
Speech.
Well, something like that. So, I'm actually going to talk about health disparities in aging, and this is actually part of another conference we did about health disparities about a month ago. I really actually think that it's very timely and very useful for us here as well. So just to get started, we're going to kind of go through what are health disparities, disparities and how they're related to aging, disparities related to minorities with a focus on Hispanic populations, and disparities related to Alzheimer's and related dementias. So again, a little bit broad and then getting very specific as to what we're going to talk about. So, what are health disparities? So, health disparities are really defined as the gaps in health or health determinants between segments of the population. And so, we're not just talking necessarily about one thing. We're really talking about a number of different factors that can affect the population. So, we also are thinking of this in a way that we're thinking of health inequalities. And the big thing about health inequalities is that these inequalities are actually avoidable. So they're avoidable, they're unfair differences in health status seen within and between populations. So when we talk about health disparities, we are identifying which populations we're talking about, and then we are identifying either which health issue and or issue in society, so social issue, that we're seeing within that population that is causing these differences. So, when we say social, we're talking about the social determinants of health, which are the conditions in which persons are born, grow, live, work, and age, and they are the factors most responsible for these overarching health inequalities. So, specifically for Hispanic populations, we tend to see some major health disparities. And so they are more likely to report fair or poor self-rated health. They're more physically unhealthy, with more physically unhealthy days and more mentally unhealthy days than others. So this is just the population themselves, what they're reporting, how they feel in comparison to other groups. They tend to experience higher rates of preventable hospitalizations, higher rates of HIV diagnosis than non-Hispanic whites, and lowest blood pressure control rates is actually for Mexican Americans overall. So all of these things, going back to kind of the definition of what disparities are, all of these things should be preventable in our society. But this is what we're seeing specifically for the Hispanic population. Another thing is that diabetes prevalency rates are very high. So we're also noticing that we have diabetes rates that are much greater than those of other groups. 2 in 5 Hispanic adults are uninsured. So again, we're not just talking about a specific diagnosis, but we're talking about a number of factors which go into or which plays into someone's overall health. So, minorities, foreign-born persons, and persons who speak Spanish or another non-English language were more likely to live near major highways, increasing exposure to air pollution, and increasing adverse health risks. So again, something that doesn't necessarily seem very health specific, but has a major health risk associated with it, or another factor that can play into health outcomes for someone. Work-related death rates unemployment rates, the highest percentage of adults not completing high school, living below the poverty level, persons living in rural areas, or those with higher percentages of older adults, lacked healthier food, and retailers nearby. So again, we're now seeing it expand to not only are we talking about things that are highly correlated with health, such as insurance, but we're also talking about things that we know relate to access. So access to nutrition, access to, or what type of job you have, and the risks associated with that, your level of education, which then can affect your knowledge base as far as what to do and to live a healthier lifestyle. So again, we're seeing all of these factors, both health-specific and social, that then come into play as far as somebody's health outcome. So, what do we need to do? So what can we do, especially as providers? What is it that we need to do to address these issues? So now that we have identified them, and we're very good at identifying things and saying, this is what's wrong, that's what's wrong, we have a problem here, we have a problem there, but what is it that we can do to actually work towards kind of figuring out why these issues exist in the first place, and then secondly, how we can eliminate them to really think about better health outcomes. So we need to identify and increase community and provider awareness of disparities and inequalities. So again, we need to make sure that we know these things exist. If we're aware, then we can provide more specific information. We can actually reach out to the communities that are more highly affected, and we can actually figure out, based on those community-based efforts, what things we can do. We also need to work to address specific disparities, especially in community populations which are experiencing a disproportionate burden of disease. So again, when we identify that, for instance, a specific population or a specific area, that they're having these issues in it, then we can work there to really address what's going on with that population and work with that specific disease process. Maybe there's something particular to that disease process, or maybe it's particular to the community, or both. And so with an overall goal to improve the overall health of all Americans, the interesting fact is that as American society, we actually do better when all Americans are healthy. This is not a factor or practice that just affects one group versus the other. This isn't a Hispanic problem. It's not, when we talk about African Americans, it's not an African American community problem. It actually then becomes a whole American problem, because our society has to figure out how to deal with all of these different issues and with all of the different communities. And it affects how we're able to provide care, and it also affects things like access, as well as really understanding disease processes more fully. So, the big thing. What about Alzheimer's disease and dementia specifically? So today, we're not going to talk about it in a more global sense, in that we're going to kind of get down to the very specific process of dementias and how they are actually really affecting communities and how that disparity, what that disparity looks like. So let's start at the beginning and let's talk about aging. So that's what we're here to talk about all week. So aging is the major risk factor for Alzheimer's disease. So people 65 years and older are the fastest growing segment of the U.S. population, and it comprises of nearly 13% of the U.S. population. And among women over the age of 65, half of them are widowers. That fact is brought up because of the socioeconomic value that it has. Because again, we're talking about kind of looking at things in a more holistic way to then address the issue. And more than 5 million older adults were below the poverty level or classified as near poor in 2001. And their primary source of income is Social Security. So again, when we talk about access to things that people need in order to improve their health, we look at finances. We look at finances and the economics surrounding it and how that affects them as far as their nutrition base, access to food, not only that, but also access to their medications and healthcare in general. So, what are the aging diversity considerations? So in 2003, 83% of the population was 65 and old. 65 and older was non-Hispanic white. But by 2050, that number is expected to decrease to 61%, with representation of ethnic minority elders in every group increasing. So, diversity in aging is going to be a very, very important issue to focus on. So, for immigrants or members of ethnic and racially minority groups, what are the things that we need to think about and consider when we're talking about aging? How is their aging process different? So, the onset of chronic illness in minorities is usually earlier than it is for Caucasians. Minorities have higher incidence of obesity and late onset diabetes. Health problems among minorities are underreported to healthcare practitioners. And so the question is, why is that? So we're seeing these interesting increases of rates and higher incidence. We're seeing higher incidences, and we're also seeing an earlier age, but yet we're also saying that they're underreported. So that's a little bit scary in that if we're already seeing that they're higher rates, and then on the flip side we're saying that they're underreporting. So do we really have the information that we need? Do we really know the scope of the issue? And why is that? Is that another access issue? So again, how do we address those questions? Minorities frequently delay seeking health-related treatments, and contributing factors to poor mental health among minorities include poverty, segregated and disorganized communities, poor education, unemployment, stereotyping, discrimination, and poor health care. So, one of the ways that this has often been conceptualized is to think of it as the double jeopardy and multiple jeopardy principle, meaning that ethnic minority and women elders have lower incomes, life satisfaction, and poor health than their white male counterparts. And so the idea is that this is a cumulative lifetime disadvantage, that this includes reduced access and underutilization of physical and mental health services that all in all results in a much greater burden and increased health and mental health problems. So again, the idea is that it's not that older adults hit 65 and minority adults have this compounded issue. It's that really what we are seeing is that these issues didn't just start when they got older. These are really a culmination of other things that have gone on throughout their lives. So we're not necessarily saying that, oh, at 65 this is when we're going to address our aging problem. We're saying that we're going to have to address this problem again throughout the lifespan. That something is going on and that these things are now having a cumulative effect on these at-risk populations. So, cultural difference. So cultural difference is another factor into how we can look at things as well. So we're not only going to just say, well, here's this one group, here's another group, we're comparing groups by numbers. We also, when we're thinking of how we're going to address issues, we also have to think of how do we include and consider cultural difference. So, well, what is culture? So, culture is defined as the totality of learned, socially transmitted behavior of a group that emerges from its members' interpersonal interactions. So that's what we think of when we talk about culture. So note that culture doesn't necessarily say that you are specifically in a certain minority population or that it has to be tied to which country you're in. Your culture has a lot to do with a number of different factors. And so it's very important to think of each individual person as to what factors kind of line up with who and what their culture is included in. Another part of that is understanding kinship systems. So these are natural, collective social relationship patterns that kind of define the group. So there are a number of different kinship systems that you can also look at when you're trying to understand a person and how they function and relate to other people. And so overall, for any individual, the distinctiveness of these components can differ based on their experience and their interpretations. So, acculturation. So, another portion of looking at this, especially in America, is that we have to consider acculturation and rate and the level of acculturation that someone also kind of what level they are at or what level they would consider themselves. So acculturation is a process that occurs when an ethnic minority relinquishes traditional values, customs, beliefs, and behaviors of the minority culture and adopts those of the majority culture. And then overall, we talk about groups, but we have to make sure that we always look at the individual. So awareness of cultural difference is important and must be included in assessment, but we also have to look, especially at older adults, as individual. So the following factors must be considered, but each individual will have their own experience, and therefore it's not just a standard. So we don't want to get in the practice of putting people into silos. We want to make sure that we consider every aspect of a person's life, what they have been exposed to, how they have reacted to that. And so we want to make sure we're looking at these different components as pieces to the puzzle and not the answer to it, that nobody is just a stamp because they belong to a certain minority group. And that is very important because when we work with research, when we work in learning, when we read a book, we're always talking about people in groups. But in reality, each and every person is an individual, and their life experience is what we need to consider. So understanding that is very important when we consider all of the statistics and all of the factors that go into kind of formulating these numbers and thinking about these groups in different ways. So, what factors and conditions can influence culture? So, immigration status, fragmented family, PTSD. So we know that for a number of immigrant populations, they actually came from war-torn nations. And so we also have to consider that not just for our veteran population, but also when we're dealing with immigrant populations, knowing that some people can often already have trauma. Who are the gatekeepers, health insurance, generational effects, education, income, health beliefs, stigma, and communication. So again, these are the areas and the factors that can be influenced by one's culture, not necessarily determined, but that you want to keep in mind when you're thinking and when you're conceptualizing a person. So, for older Hispanics, and again, this is not to just put a stamp and say that this is going to happen, but these are the statistics that we have right now. So the fastest growing segment of our older adult population, and thought to increase to 18% of any race over 65 by the year 2050. The least educated group of elders, family-oriented, and will often seek guidance and assistance from families first, and can consider a provider family. And one way of thinking about how to communicate better with people. Religious, with approximately 95% Catholic, exhibit prominent gender roles. Older are often less acculturated than younger, and look to professionals as experts. So again, these are some factors, do not describe all people, but some factors that have been fairly consistent in the group. Now, when we talk about dementia, so again, probably heard about dementia today, but dementia is the profound deterioration of mental functioning characterized by impaired memory, thinking, judgment, and language use. And the most, and with dementia of the Alzheimer's type being the type that is most diagnosed. With vascular dementia also being a fairly high segment, especially in our population here in the VA. And others include HIV, Pick's disease, Huntington's disease, other types of processes that can affect, again, a person's mental status. So, specifically when we talk about dementia of the Alzheimer's type, and again, this is the DSM-4 version of of talking about Alzheimer's disease. But the reason that I present this is because we think of the memory loss, and we usually focus on that. But one thing I like to make sure I point out is that there are one or more of the following cognitive issues that a person will also have, which include aphasia, apraxia, agnosia, and disturbance in executive functioning. So again, we likely see a number of these cognitive issues. So not only one area is affected, but we actually can see that there's cognitive impairment across multiple areas. And again, that what we're seeing is not only this decline in cognitive functioning, but we also usually see a decline in the person's, as well as their functional status, so what they're able to do and what they can do for themselves. So what you look for is there is an impairment of their social, occupational functioning as well, and that this decline is usually seen over time. So you usually see a steady worsening, and you don't really see kind of a one point in time change. So there again, that this isn't caused by any other type of neurodegenerative process or of anything else that could have possibly been identified, including other reversible causes of the disease, and as well as substance-induced conditions and mood disorders as well. So, what's the prevalence of Alzheimer's disease? So, it's thought to be a current and a future public health crisis. So, with the number of older adults, with the older adult population in America increasing, what we're estimating is that there's probably going to be 2.4 to 5.1 million people in the United States alone with Alzheimer's disease. And, you know, that will put a significant strain on our healthcare system. And with this prevalence of Alzheimer's disease being higher in Hispanics than it is in non-Hispanic whites, that means that this crisis will affect the Hispanic population much more greatly, or than it will necessarily the non-Hispanic white population. But again, when we talk about these things, it's not necessarily that we're thinking that one community is just going to be affected. This is going to then affect the whole structure of our community and the organization of our healthcare system. It's going to have much greater effects than just saying, oh, well, this is going to affect the Hispanic community. That's not true. When we have to take care of people with a dementia, and we have to take care of people who can live 10, 15 years with a dementing illness, we're going to have to figure out how to do this as a society. So, health disparities in Alzheimer's disease specifically is that there's an earlier onset and greater severity of symptoms at the time of first evaluation. So again, we're not necessarily clear if the first evaluation is taking place early enough or if it's taking place much later than it is for other populations. Interestingly, in the Hispanic population, the ApoE gene has no association with cognitive decline as it does in non-Hispanic whites and in African Americans. This is a very significant finding because this is one of the directions that a lot of genetic testing is going down when we're dealing with Alzheimer's disease. So this is another example of why we're not asking the question about a specific population just to label that population, but we need to include people in our research studies so that we can more greatly understand how our disease process affects that population so that we can then treat and understand and not make global assessments and then interventions that are not based on our total population. Cognitive testing is also not as effective in predicting future impairment in minority groups. One reason for this has a lot to do with education levels, especially in older adults. This usually has to do with the fact, going back to saying, oh, the older Hispanic population has the least years of education. That's one factor. We also have the factor of English as a second language. So what we know is that we have to improve our assessment tools so that they are able to better assess minority populations so that they are better able to account for those education differences. Again, it also has to do with how we are evaluating those testing procedures. What are the populations that we're looking at? Have we effectively used that tool on all populations? So it's not that our cognitive testing isn't working or providing us with valuable information. It is just not as specific to our minority populations, and most likely that's due to the populations that we've done the research with. So, why the differences? Why are we seeing these things? So again, social factors influence the development of the disease community and environment. So when we think about the one factor, we're not just thinking about the physical. We're thinking about, well, what's going on? What things socially could possibly influence this? Specifically, lower education status influences cognitive assessment, as I said. Also, we're talking about resources. And not only resources, but then healthcare and access and utilization. So does our minority population know and understand when it's time to go to the doctor about being assessed for a cognitive issue? Are we able to tell? Are we educating our population about health issues in a way so that they know that there's a problem before the problem gets to be so bad that they're unable to care for the family member? Are we understanding that aging does not equal cognitive impairment, and which isn't necessarily known in a lot of different places? Are we knowing what we need to look for and what are the early identifying factors? And then the other big difference is just overall poor health. So we have seen with Hispanics and with African Americans that we are seeing at least about a decade difference in some of these chronic illnesses. And so with that, are we just really getting people who have poor health overall? And so some of this decline is being attributed to the other health factors. So again, all of these questions that we need to figure out answers to. So how do we address the disparities? So the first is access to healthcare and healthcare utilization for not only prevention, but also early detection, which would be of the utmost importance to influence the negative effects of what we talked about before with the double and multiple jeopardy. So one of the factors is to how do we understand what these cumulative effects have been, and how can we then influence them earlier? And then the other one is research. So again, I can't stress enough that we really need to understand the functioning of the population. So minority, rural populations, it's necessary to gain understanding of how Alzheimer's disease and other dementias present and progress in other populations. So again, we need to be able to do this research on minority populations, especially when we're looking at things like genetics. We need to understand what the factors are, how this is expressing itself in other populations, and when we are trying to figure out early treatments, or even what can help us with prevention later on. And so that's the... Move through that today.